Hello, hello, Drew. Hello, guys. How are you? And I think all of you are doing good at home. Drew,
Yes,
I'm
you are
audible
audible,
there
sir.
on. Yeah.
Yes, sir.
Okay.
Clear.
Okay. Okay. Doctor Anshu must have covered pathology and pathogenesis of rheumatoid arthritis, one of the commonest autoimmune disorder, which is seen in India and in most of the countries. So, a word autoimmune means in layman's language or in our simple language also. It's something like body cells are fighting with themselves. So, what this autoimmunity causes, like there can be external causes, there can be internal causes, there can be genetic causes, and multiple. And some causes are not known. Till now, nothing is clear or something is not clear. So, whatsoever it uh, behind the curtain, whatsoever is happening by autoimmunity, what is problematic is the patient is having problems. The patient is having symptoms. They, they have sufferings due to all these disorders, and one of the most common is rheumatoid arthritis. That's one of the autoimmune rheumatological disorder. So if we go, that's rheumatoid arthritis affects approximately 0.5 to 1% of adult population worldwide, and the overall incidence has been decreasing in recent decades, whereas the prevalence has remained the same because of individual with RA, means rheumatoid. I will be pronouncing rheumatoid arthritis as RA henceforward. So RA are living longer. So the life expectancy has increased. So the prevalence is increased. The disease number of disease persons has increased. But then, as you know, incidence and prevalence, incidence is new disease happening, the new disease which is diagnosed, and prevalence is whatsoever are disease which are there in the population. So the prevalence is increasing, but the incidence is decreasing over the time in world. So this is a map showing that what are the incidences around the world, and if you see the percentage, oh, worldwide or over the globe, it looks like the same, like around uh, 1.5%. So 1% of Indian population makes a big chunk of people which is having this disease. So this, so we will be looking henceforward that what are the problems or what are the clinical uh, presentation of this disease. So RA occurs more commonly in females than in males, and the proportion is 2 to 3.1 3 is to 1. Means 3 female is to 1 male will be the proportion, and the proportion in all autoimmune disorders, mostly all autoimmune disorder, is females is having larger presentation than males. If you go for another disorder called as systemic lupus erythematosus, the incidence is around 8 is to 1. So 8 female is to 1. So this happens only, it is seen only in cases of autoimmune rheumatological disorders. In Latin America and African countries show an even greater predominance of disease in females, which is around 6 to 8 is to 1, which is quite higher. As I told you, SL is having this proportion that 8 is to 1, 8 females, and one is against that one male will be affected. So this is the thing. Various theories have been proposed to explain the possible role of estrogen in disease pathogenesis, but nothing is confirmed. So what they blame is for estrogen in enhancing the immune response. Experimental studies have shown estrogen can stimulate production of tumor necrocytes alpha, and the mechanism or the chain reaction start. TNF alpha, interleukin, cytokines, different things, and this causes autoimmune reaction. In pathology, you must have learned that how that inflammation starts and what these different factors like TNF alpha, interleukins, other cytokines white blood cells, how they act and how they start process of inflammation or chronic inflammation. We come directly for clinical features. That's RA increases between the 25 to 55 years of age, after which it plateaus until the age of 75 and then decreases. So if you say that elderly population is less likely to have RA, this is for starting of the disease. This is not for if a patient is diagnosed at the age of 50, that doesn't mean that it will stop at the age of 75. One thing in starting is to remember this RA is not a curable disease, it's a treatable disease. Curable disease is that where the disease is eradicated from the patient's body, like tuberculosis. Tuberculosis can be cured, but HIV can be treated. Okay, so these two things are different. So RA is also treatable; it's not curable. The presenting symptoms of RA typically results from inflammation of the joints, tendons, and bursas. So I don't want to go into details of what are joints, what are tendons, and what are bursas. But as you can see here, this is a normal joint. Tendons will be coming here, and on the lateral side also is in cartilage, the synovial fluid, and the capsule. If you there are another disorder as the age goes on, like in osteoarthritis, that is an age-wise disorder due to the rubbing of two bones around each other and loss of cartilage in the joints. This is called as osteoarthritis, and this is another joint of rheumatoid arthritis. So what you can compare directly with this normal joint with the rheumatoid arthritis joints is bone is eroded, the cartilage has gone, and you can see the thickness of bone here. This is the tibia and fibula. Tibia and femur. There's two head of uh, head of femur with this tibia. You can see there is erosion here, the loss of bones. It is inflamed. You can see there is no inflammation in the capsule, but here it is inflamed. There is deformity within the bone, in the capsule also, and as everything there at the joint is deformed, so ultimately it will cause problems with tendons also. So we'll be looking this in further slides. Many patients come with this type of thing, like he or she is having joint pains. So it can the joint pains are divided into inflammatory and non-inflammatory. Inflammatory is a word in medicine is for inflammatory joint pain is for the pain due to this rheumatological disorder. Non-inflammatory can be trauma, it can be infectious, it can be sprain, it can be muscle tear, it can be cartilage tear, it can be capsular injury. So we are at the articular thing with inflammation of thing in inflammatory thing, then it will be autoimmune or rheumatological disorder. So how you go further is initial rheumatic history and physical examination to determine is it articular, it is acute or chronic, is it inflammatory, and how many, which joints are involved. So how many and which are important as the diagnosis of rheumatological disorder goes on. So I will be telling that. So is it articular or not? If not, it is non-article condition like trauma, fracture, fibromyalgia, bursitis, tendinitis. If it is yes, the complaint is more than 6 weeks. If it is yes, then it is chronic type. If it is acute, it is less than 6 weeks, it is acute, then we will consider it as acute arthritis, can be due to infectious arthritis, gout, pseudo gout, reactive arthritis, initial presentation of chronic arthritis. But we will be looking on the right side only today. That is articular with chronic thing. That is more than 6 weeks. So is inflammation present or not? So is there prolonged morning stiffness? Is there soft tissue swelling? Are there systemic symptom? Is the ESR and CRP is elevated? So if it is yes, and it is chronic inflammatory arthritis, how many joints are involved then? If it is more than three, it is chronic inflammatory polyarthritis. Is involvement symmetrical or asymmetrical? Symmetric means left and right. So if you see axial skeleton means spines, if we consider midline as spine, so right side and left side both joints are involved, then it is called as symmetric. So if involvement is symmetric, if it is yes, are this interphalangeal, proximal interphalangeal joints are involved, or metacarpophalangeal joints are involved, or metacarpotarsal phalangeal joints are involved. If it is yes, then it is rheumatoid arthritis. I will not go further of psoriatic or reactive arthritis, but the chart is the same. That the history goes out like this, and on this history with other supportive findings, you have to go further. Just have a look that if we followed that what type of arthritis it is inflammatory, non-inflammatory, is it chronic or acute, is it associated with other thing like increased ESR, that is erythrocyte sedimentation rate, and CRP, C-reactive protein. So if that is raised or not, yes. Then if that is raised, then we had gone into how many joints were involved. So if it is more than, and which joints are involved, the smaller hand joints are involved, symmetric presentation, and it is chronic presentation, then it is probably rheumatoid arthritis. So if we go here, what I say is distal PIP, this is proximal PIP, then interphalangeal joint, this is this is proximal, this is distal interphalangeal joint, this is metacarpophalangeal joint. So this is PIP, this is DIP, this is MIP. Okay. So what you see here that rheumatoid arthritis happens in PIP and in MIP. This is metacarpo interphalangeal joints. Also, it can involve the wrist joint. Other joints are also involved, but in rheumatoid arthritis, small joint involvement is must, or around 90 to 95% cases, this is involved. So these are this figure also suggests different types of other like DIP. If DIP is involved, then it is osteoarthritis, psoriatic, or reactive arthritis. But we will only focus on uh, rheumatoid arthritis today. So, if it is involving proximal interphalangeal joints of both hands and wrist joint, no thumb involvement is seen. This OA is osteoarthritis. The earliest involved joints are typically the small joints of the hands and feet. The initial pattern of joint involvements may be monoarticular, oligoarticular. Monoarticular means single, oligoarticular means less than 4 joints or 4 joints, and polyarticular is more than 5 joints. And this is usually symmetrical. The joints polyarticular means multiple joints. It's not one area. It will be like two wrist, means we will be considering two joints. If two wrist with two elbow with two shoulders, then it will be 6 joints. Okay. The acute onset of polyarthritis is associated with prominent myalgia, fatigue, low grade fever, weight loss, and sometimes depression because of the chronic illness. Morning stiffness and decreased grip strength, although all peripheral joints are involved. So that's why the stiffness in the morning is a problem. Now, what morning stiffness means in rheumatoid arthritis? What the patient tells here in India, like in Hindi he will say, or in Marathi he will say, then when he gets up, he is having problem. The joints are not moving, so they are painful. And as the sun comes up, जैसे ही धूप आती है, धूप आने के बाद उसके joints खुलने लगते हैं, and they start working. So it's nothing to do with sunlight. What the patient thinks is that when he gets up around at 7 o'clock, the sun is not so much bright. So what happens is around within 1 to 1.5 hour or 2 hours, the joint becomes free. This is just because the movement is decreased in sleep time. That's why joint gets much fixed because of the chronic inflammation. As they start movement, that causes increase in movements causes a bit flexibility in the movement, and that's why patients feel that as the brightness of the sun increases, patients uh, problems of that stiffness or not moving of joint decreases. So this is morning stiffness. So this is most important in cases of rheumatoid arthritis. Less common in proximal joints. Uh, Morning stiffness is less common in proximal joints. The axial skeleton is usually spared other than cervical spine. Axial skeleton means from cervical spine, means from the first vertebra up till the sacrum is axial skeleton. Includes rib joints also, means the spino rib joints. So that also, so that is not involved in cases of rheumatoid arthritis. Can anybody tell in the chat box that which is, and not seeing on, not googling it? If you remember, just tell me that which is the most common rheumatological disorder in which axial skeleton is involved. Most common. Okay. And that is something to do with GI tract also, that is something to do with psoriasis also. Okay. And definitely it is not psoriatic arthritis. So continuing the topic, the axial skeleton except cervical spine is not involved. Poorly controlled disease typically experience progressive joint damage, which may result in significant joint deformities and functional impairment. So this happens over years. This happens over years. It's not a one-day phenomenon. It's not a one-month phenomenon. It happens on months and years, and then the patient is having this loss of uh, joint space, loss of uh, capsular problems, joint capsular problems, and formation of deformities. So there are around three types of presentation as per as how this present, not for joints, but how they present, like in between how the patient will be and affected area time of that patient. One is called as typical classic RA, that is insidious with predominant symptoms being pain, stiffness, especially morning stiffness, I told you, and swelling of many joints. The MCP, this metacarpophalangeal and proximal interphalangeal joints of the finger and interphalangeal joints of the thumb, the wrist, and tarsophalangeal joints of the toes are sites of arthritis in the disease. The proximal joints are less common. So, joints of hands and joints of legs are involved, and proximal joint involvement means shoulder, elbow is less common. Another presentation is palindromic rheumatism. The onset of RA is episodic in few patients with one of to several joints areas being affected sequentially for hours to days, alternating with symptom-free periods that may last for days to months. This episodic pattern is referred to as palindromic rheumatism. So, problematic period, a normal period, and again this get repeated. But nobody knows that when it will start and how many days it will remain and how many days the patient will have symptom-free period. The proportion of patients presenting with palindromic rheumatism progresses to develop RA over months to years in most. Another rare presentation is monoarthritis, persistent single joint arthritis, that is monoarthritis, frequently of a large joint such as wrist, knee, shoulder, hip, or ankle, and may be a sole manifestation of RA. The interval between the monoarthritis and polyarthritis may extend from days to several weeks in patients whose disease progresses. So ultimately, this monoarthritis will go into polyarthritis, and single joint will go into multiple joint involvement, but it will take some time, and but the presentation or diagnosis will be monoarthritis. Once the disease process of RA is established, the wrist, metacarpophalangeal joint, the PIP joint stands out as the most frequently involved joint. As I told you, it will be a distal disease, no proximal, less common proximal involvement, and the DIP joint involved may occur in RA, but it's usually a manifestation of osteoarthritis. If you remember that picture about which joint involvement, which disease. So in that picture, in this picture, as you can see, this DIP is involved in cases of osteoarthritis. So it's the same thing. If DIP is involved in RA, then it's usually associated with osteoarthritis. Trigger finger, there is a phenomena that is flexor tendon tendonitis is a frequent hallmark of RA and leads to decreased range of motion and reduced grip strength. As same happens in cases of morning stiffness. So this is a word which can be an MCQ question that trigger fingers are seen in which disorder. Now we come for deformities because there are multiple questions that this deformity is seen in this penicillin cup deformity. If somebody can answer that penicillin cup deformity is seen in which disorder, which is obviously not seen in rheumatoid arthritis. So tell me about that also, that if anybody knows. But this also have around 4 or 5 deformities which you have to remember. So one deformity is swan neck deformity. This is progressive destruction of joint and soft tissue may lead to chronic and irreversible deformities. Ulnar deviation results from subluxation of MCP joint with subluxation of parent proximal phalanx to the volar side of hand, hyperextension of PIP joint with flexion of DIP joint. So this is a swan neck. So this is hyperextension and this is flexion of DIP. This is PIP, this is DIP. So this is a swan neck deformity. Another thing is another deformity of the same patient will be duck bill deformity. This is a duck bill deformity and it will be fixed. These deformities are fixed. It cannot change because this deformity happens in long run or time taking months or years to form, and this deformity will not go in except doing operative thing. So if you are not doing operative thing, then this deformity will not go. Okay. And this operative thing will be dealt with Dr. Kiran Mandile tomorrow. Another deformity is Buttonier's deformity. As you can see, flexion in PIP joint with hyperextension of DIP joint. You can see here in this picture, this flexion at PIP and extension at DIP. Another is Z-line deformity. It is subluxation of first MCP joint with hyperextension of first interphalangeal IP. This is IP joint. As you can see Z, where is the Z? This type of deformity is seen. This is a Z deformity. Okay, you can make it out that the shape of the hand is definitely changed. What the prior deformity, two deformities that only fingers were having problems. Now here you are seeing that on the wrist only it is seen like the hand is from the wrist joint it is deviated to the medial and from the PIP or DIP it is deviated to the lateral side. Another deformity is called as piano key movement deformity. This is piano key movement deformity. It is inflammation about the ulnar styloid and tenosynovitis of the extensor carpi ulnaris may cause subluxation of distal ulna, resulting in a piano key movement of the ulnar styloid. This is called as piano key movement deformity. Another deformity is the ankle mid-tarsal regions are usually affected later in the course of the disease and often predisposed to pes plano valgus, that is flat feet. Now this is the shape of foot. It is lost, and you can see that it has become flat. Also, you can see swelling here on the first metatarsophalangeal joint, and the shape of one finger you are seeing here, that is deformed. Also, the great toe is laterally deviated. So there is flatness. Main is the flatness of the foot. The large joint, including knees and shoulder, are often affected in the established disease, and as told, it is many years after the onset. The main thing to remember here that this is the disorder in which axial spine is involved is only cervical spine. So as I told you, there is atlantoaxial, that is C1 and C2 is only involved, and this can cause problem. So it is a potential to cause compressive myelopathy. Compressive myelopathy means compression of the spinal cord. Myelopathy means a problem with the spinal cord is myelopathy, and compressive means there is a compressive etiology of there is a compressive pathology. So something compressing from the outside is called as compressive myelopathy. As you can see here in this picture, is C1 and C2. What can happen in rheumatoid arthritis is there can be subaxial instability. Instability means that this normal joint is there between 1 and 2. So, and there is cartilage in between. So what happens is there is instability. So this body of this vertebra can move back and can cause problems here and can cause compression over the spinal cord. This is spinal cord, this is spinal cord, this is medulla, and after that spinal cord, this is medulla, and after that spinal cord continues. So it can cause compression. Second, in this picture, it can cause proximal migration. The semen, this odontoid process, can migrate up and can cause compression over the medulla also, can cause compression over the spine also. So if it is compressing over C1, C2 level, then there will be loss of phrenic nerve also. As you know, this phrenic nerve root value is C2, C3, C4. So there will be respiratory compromise also. And if medulla is involved, it have a cardiac center also. It have uh, respiratory center also. So the respiration and cardiac centers will be affected. Now we come for the
Um,
extra-articular. Yeah,
Sorry to interrupt, sir.
yeah.
Students have answered to your first question that
Okay,
most
okay.
common autoimmune disorder involving axial skeleton. There are two answers I can see in the chat box: osteoarthritis and ankylosing spondylitis.
Yeah, the first answer is wrong. The second answer is right. It is ankylosing spondylitis. Okay, that is in a group called as spondyloarthritis. Spondyloarthritis is a group in which HLA-B27 is positive. So it is there is a relation between HLA-B27 and spondyloarthritis. In that spondyloarthritis group, it have Ritter's disease also, it have psoriatic arthritis also, and the leader of that group is ankylosing spondylitis. I said about that the same disorder will have GI symptoms also. So the ankylosing spondylitis is also there is a relation between inflammatory bowel disease with that of ankylosing spondylitis. So if whosoever person has answered this, then please answer that ankylosing spondylitis is associated with which GI disorder means inflammatory bowel disease. There are two types of inflammatory bowel disease. One is ulcerative colitis and another is Crohn's disease. So in which disorder it is associated? So should I move on with this topic now?
Sir, can we go ahead with two questions, two doubts in the.
Yeah, yeah, yeah.
So there's one question which says that does RA increase the risk of osteoarthritis in later age?
Hmm. See, osteoarthritis and RA can go hand in hand. That is because the osteoarthritis is something related with age, with hormones, with weight, with the mobility of persons. So that depends on that. Per se, RA doesn't increase the chances of osteoarthritis. But yes, definitely RA can be associated with osteoarthritis. But we cannot make two things that because of this that happens. No, Neither osteoarthritis can cause rheumatoid arthritis, neither rheumatoid arthritis can cause osteoarthritis. Both have different pathogenesis, but definitely over the time as the patient's age increases, these both disease can go hand in hand. But as the pathogenesis and as the causes are different, so both can go hand in hand, but both cannot cause each other. Second,
Okay, sir. And the second doubt was, what is Dequervain's tenosynovitis?
Recurrence sinusitis is not associated with this. If you are we continue with another rheumatological disorders, I can explain that because all these disorder needs pictures or some good things, the pictorial presentation because to get it remembered. Okay.
Okay.
Uh,
Okay, sir. So, and the GI tract disorder, students are saying Crohn's disease is most commonly associated.
yeah. I can again ask another question for all these questions are like MCQ questions. You people will remember it for many long days. Like it will help you out in your NEET examination. So, which antibodies are associated with Crohn's disease? Okay, next question of just related with this. And another thing is that having ankylosing spondylosis with Crohn's disease is a good thing or a bad thing? Okay. So should I move on with this with
Um,
this topic?
so,
Any
so
more question?
no more questions yet, but someone has answered anti-Saccharomyces antibody. ASCA,
The pardon?
the antibodies involved are
Yeah,
anti-Saccharomyces antibody, ASCA.
ANCA, ANCA.
It's ASCA in the chat box. Um,
It's not ASCA, it's ANCA.
okay.
Okay, okay, you're right. So I will moving on with this topic that I told about the cervical spine will be involved. So in extra articular manifestations, like it can cause subcutaneous nodules. It occurs in 30 to 40% of patients and more commonly in those with highest levels of disease activity. A positive test for serum rheumatoid factor, I will telling you what is rheumatoid factor means, and a radiologic evidence of joint erosion. When palpated, the nodules are generally firm, non-tender, adherent to the periosteum. Skeleton subject to be repeated, it's usually seen in repeated trauma over that, or irritations such as the forearm, where it is formed repeatedly trauma ho raha hai wahan pe, or irritation as it happens in forearm, sacral prominences, and Achilles tendon. They may also occur in lungs, pleura, pericardium, and peritoneum. So it can be outside also, it can be inside also. Nodules are typically benign, although they can associated with infection, ulceration, and ganglia. So it's nothing to do with any tumor. It is chronic inflammation which causes this formation of nodules. As you can see, this type of nodules are seen over the forearms. This is subcutaneous nodules of rheumatoid arthritis. Another syndrome which can happen is a Sjogren's syndrome. It is the presence of either conjunctivitis sicca, that is dry eyes, or xerostomia, that is dry mouth, associated with another connective tissue disorder such as RA. Approximately 10% of patients with RA have secondary Sjogren's syndrome. Now, what Sjogren's syndrome is? A syndrome of glands. This exocrine gland that which secretes saliva, so it can involve eyes also. It can involve exocrine gland only. It can involve eyes. It involves eyes also. So the tears in the eyes decreases, and the tear that tear in eye decreases, then it will cause irritation because tears have lubricant phenomenon also. It's antibacterial also. It is also useful in washing eyes because small dust particles. So if it is that is remaining there, if there is no flushing, there is no antibacterial effect, there is no lubrication, irritation will happen. If irritation will happen, cornea will be eroded. If cornea will be eroded, there will be infection and ultimately giving rise to corneal ulcer. If saliva is decreased, there will be problems in swallowing because saliva is also lubricant. It is also having digestive enzyme. It is also have antibacterial effect. Another thing is, as so saliva is not there, dental caries will increase because it increases the chances of dental infections. So this is Sjogren's syndrome, which happens in cases of rheumatoid arthritis. So you can see there will be ulcerations here in conjunctiva. So oral ulceration will be present, as I told you why it happened. Dental caries. Okay. So it is Sjogren's syndrome. What the pulmonary involvement is, it can involve pleural disease. The most common pulmonary manifestation of rheumatoid arthritis may produce pleuritic chest pain and dyspnea, that is difficulty in breathing, as well as pleural friction rub and effusion. That is the clinical finding. Pleural effusion tend to be exudative with increased number of monocytes and neutrophils. Another thing is it can involve interstitial lung, means lung parenchyma. So that is called as interstitial lung disease. May also occur in patients with RA and is heralded by symptoms of dry cough, progressive shortness of breath. Diagnosis is readily made by HRCT, this is high resolution chest radiography or chest tomography and pulmonary function test. The presence of ILD, that is interstitial lung disease, confers a poor prognosis with cases of rheumatoid arthritis. The prognosis is not quite as poor as that of idiopathic pulmonary fibrosis because ILD secondary to RA respond more favorably to immunosuppressive drugs. Now you can have ILD because of other things also, because of allergens, because of pollution, because of n number of factors other as we go in the respiratory system. But if it is due to rheumatoid arthritis, then it is having a better prognosis than this. But it doesn't mean that RA with ILD is good. No, it is not good. It is also have a poor prognosis. But if ILD is due to some other cause, then it is having good prognosis in RA than ILD due to any other cause. So these both statements are different. So don't misinterpret these both statements. There's the same nodules as I showed you last 2 3 slides back. Is pulmonary nodules can be present. There can be solitary or multiple. So of that nodules is called as Kaplan syndrome. The Kaplan syndrome is a rare subset of pulmonary nodulosis, characterized by development of nodules and pneumoconiosis. As you can see in this chest X-ray PAU, this white is called as radiopaque nodules are seen here, 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 here. This rounded shadows, these are nodules. This is called as Kaplan syndrome with rheumatoid arthritis. And single or multiple nodules may be seen. In cardiac involvement, 10% of patients with RA, despite the fact that pericardial involvement may be due to detected in nearly one half of these patients by echogram or autopsy studies. So around 10% of population will have involvement. They can have cardiomyopathy, means problems with the muscle of heart, necrotizing, sorry, uh, necrotizing or granulomatous myocarditis, again the inflammation of myocardial muscle, coronary artery disease or diastolic dysfunction. Mitral regurgitation is the most common valvular abnormality. Now, uh, heart have muscle, walls, coronary arteries, and different vessels which are coming in and coming going out. So the most common valvular disorder is mitral regurgitation. The most common muscular issue is cardiomyopathy. The most common ischemic event is coronary artery disease. So these things are different, but heart is
Samir sir, we are not able to hear you.
Just a second, everyone. Samir sir has gotten disconnected. He'll be connecting soon. Just hold on for 2 minutes, please.